Morning, children. Let me start my class. Let me share my screen first. Today's topic, what I'm going to say is introduction to fixed partial dentures. Share my screen. Okay. So you have heard the word fixed partial dentures, removable partial dentures, and complete dentures. This is the basic three methods of dividing how the tooth has to be fixed to the oral cavity. Either you can fix it, either you can have a removable type, or you can have a full set of complete dentures. So today I'm going to talk to you about what an FPD is, what are the contents, then what are the parts of an FPD, when it should be used, when it should not be used, and its classifications. Let's come into detail. So, the nature of an fixed prosthodontic treatment can vary from restoration from a single tooth rehabilitation to entire dentation. These restorations can instantaneously restore the image and the confidence in the patient. The technique, this is a technique sensitive work which requires skill and a thorough knowledge. It involves tooth preparations and a knowledge regarding the restorative materials, how it should be used, what all type of impressions should be carried on, and all these things, and what are the different types of fixed partial dentures are available, and what all situations which should be used. Coming to the definition of fixed prosthodontics, the branch of prosthodontics is concerned with replacement or the restoration of a tooth by an artificial substitute that are readily removed from the mouth. Fixed partial dentures or the FPDs, a dental prosthesis that is luted or screwed or mechanically attached or otherwise secured, tightened to the nail or to the tooth root or by a dental implant. Abutment that furnishes the primary support for the dental prosthesis. They are commonly referred as bridges and cannot be removed from the patient by himself. The supporting teeth are termed as abutments. The restorations that are cemented into it are retainers. Artificial tooth replaces a replacement in the set is known as a pontic, and the retainer is connected to the pontic by a connector. So basically there are four terminologies. One is abutment, which is supposed to be the supporting, and the second one is the retainer, and the third one is the pontic. Pontic is the tooth which comes in between the abutment and the retainer, and these pontics are connected to the retainer with the help of connectors. Hope it is clear. So as the picture shows, you can see two tooth and one edentulous area. So this two tooth, you call it as an abutment, and this particular edentulous space area, you are giving an additional artificial tooth, and this particular tooth you call it as a pontic. And this there are the pontics. The pontic will be connected to the retainers with the help of a small connector. Okay, so let's see. The first thing is a crown. Crown is an artificial replacement that restores the missing tooth by surrounding parts or all the remaining structures with a material such as cast metal, porcelain, or combination of materials such as metal and porcelain. This is according to GPT-8. It is basically a crown. It is basically cemented extracoronal restoration that covers or veneers the outer surface of the clinical crown. It should reproduce the morphology and contour of the damaged coronal portion of the teeth and also protect the remaining teeth structure from further damage. If it is covers all the surface of the clinical crown, it is called a complete crown or a full veneer crown. If only a partial portion like this, a partial area is being covered, then we call it as a partial veneer crown. And the another terminology is known as laminate veneers. This are, you can see in this picture, a thin pink color is going out here. So this is a very thin bonded restoration that restores to the facial surface part and of the proximal surfaces of the teeth requiring an aesthetic restoration. So it covers the facial surface, likewise a part of the proximal surface. So you can see the facial surface is clear and only a part of the proximal surface is being touched by a laminate veneer. So they are fabricated from resins or dental porcelains and they are bonded by an adhesive cement to etch to the enamel with a composite luting agent. And I do repeat, this restoration is only limited to the enamel preparation. Now, coming to bonded restoration, it is a fixed dental prosthesis that looks to the tooth structure, primarily the enamel, which has been etched to provide the mechanical retention and for the resin cement. The tooth preparation is limited to the lingual or palatal surface and is minimal. See, you can see that the tooth is missing over here and a tooth material is given over here and an abutment tooth is given. So it is something like an abutment tooth with a wing, and this wing gets detached get attached inside the lingual side. So hope you can appreciate this. This is the pontic, and these are the two natural tooth. Behind the pontic, there comes two metallic wings, so which will be sticking on the back side of these two tooth. And this is a particular mirror image. Hope you could understand. Then radicular retained restorations, or else you can call it the post and core system. So it consists of a post or a dowel which is attached to the core. And the post is a prepared radicular space endodontically treated in an endodontically treated tooth. The core offers the support of the crown. So basically, if you have an endodontically treated tooth with less of coronal structure, you try to preserve the roots, the existing motolated tooth. You remove, you do a perfect RCT. After that, you insert a post. This in the middle of the radically prepared area, and on top of it, you build up a core like a tooth, and on top of the core, you will be giving a crown so that your tooth can be restored. So when do you go for this? And when do you go for an FPD? So FPD you can be used in short edentulous areas, abutment teeth with the supporting tissues if they are healthy, and to harmonize the dental occlusion in TMJ disorders to re-establish and to splint the dentation after an advanced periodontal therapy. All these things you go for an FPD. And when the patient desires a fixed prosthesis, the patient has the skill and motivation to maintain a good oral hygiene and a prosthetic oral hygiene. And when the removable prosthesis is not indicated as in mentally or physically challenged patients. So coming to the contraindications when you should not use this, the edentulous spaces with no distal abutments, long edentulous spans, bilateral edentulous spaces with more than two tooth missing on the either side which require cross-arch stabilization, the presence of periodontally weakened abutments, the teeth with a short clinical crown are likely the congenitally malformed teeth. The contraindication, severe bone loss of the tissue in edentulous areas because of the surgery or trauma. The patient has poor oral hygiene, a very young patient with a wide chamber, very old patient which of the brittle teeth and medico-legally compromised patients. The advantages. The advantages is the aesthetics, first of all. Second, the patient feels more comfortable. The patient does not have to take out his tooth and clean it like an RPD after each time of food. He is more comfortable while wearing this. The capability and the direction forces along the long axis of the tooth. Then the superior strength of this FPD provides a proper occlusal function, maintains the integrity and the tooth positions, maintains occlusal relationship, protects and preserves the remaining structures. So the disadvantage, it involves this irreversible preparation of the abutment tooth. That means once if you are reducing or else you are preparing an abutment tooth, this preparation or else is irreversible. You cannot build back the lost enamel. So abutments are susceptible for a recurrent decay. Reparations might incur periodontium or the pulp. The cost of making a prosthesis is costly, and the creations of diastema is also a little bit difficult. The classifications of FPD. FPD can be classified on the basis of criteria. One is the location of the dental space, the location of the abutment, what is the type of connectors used, the type of material used, the duration of the use, the span, the length of retention, and the type of support. So coming to the dental space, posterior, first in posteriors, FPD conveys to the posterior by replacing the molars to the premolar region. So in posterior region, the aesthetics is of less of concern. Then coming to the anterior zone. The anterior zone, the FPD consists of missing the central incisors or the lateral incisors, etc. Then coming to the combination of two, maybe the FPD extending anteriorly from both anteriorly, likewise posteriorly. In such cases, like replacement of the canines, or else if you have to replace the premolars, it should have a combination of tooth anteriorly and posteriorly. And coming to the location of the abutment. The abutment is located adjacent to the edentular space, and the formic is supported from both sides. And this is the design of the majority of FPDs. What is a cantilever? Cantilever, the abutment is located adjacent to the edentular space, but the pontic is supported only on one side. The other side, there won't be no abutment tooth. Then comes to the spring cantilevers. Spring abutments that are located adjacent to the edentular space and the pontic receives support only from one side, or else you can call it if the abutment tooth located near to the edentular space is not capable enough to take up the load of the replacing tooth, then any other tooth from the posterior region may be taken with the help of a spring to support the anterior tooth to replace the particular area. So like it is shown in the picture, you can see a U-loop connector. See, you are replacing a centrals. Maybe this laterals won't be of sufficient support, and you know that this particular tooth is your canine, which is in the corner area. So better than using a canine, a single tooth can be replaced with the help of a spring cantilever. So a support is taken from the premolar and it replaces the incisor. So the advantage of such a restoration is that the amount of subunits made is less. If you want to restore this, you will have to take support from one. You will have to have units like 1, 2, and 3, or else canine to canine. If the lateral is periodontally compromised, then you will have to take the support from the canine. So the number of units is high. So to reduce the cost, a spring cantilever can be tried. But the disadvantage of this is it might interfere with the tongue. It might cause, since this bar is touching the palate and running, it might cause irritation like that. And coming to the type of connectors, what are the different types? One is fixed connector, fixed removable connector, and a fixed removable connector. That is, one is fixed to fix, and the other is fixed. One side is fixed, the other side is movable. Then the other type is fixed and removable, like that. So let me explain to you in detail. So if it is a fixed connector, both the sides, the contics are with are connected with a rigid connector with no mobility. So you are taking support from these two tools, and you will have a rigid connector in middle of this. And coming to fixed movable means it is given in special conditions. Like you must have heard about a fire abutment. Fire abutment is nothing, is the name which we call for the tooth which is in the middle, which is having an edentulous space and from mesially and distally on the tooth. So when you give a fixed abutment in such a condition, what happens is this fire abutment takes up the load and this will act like a fulcrum point. So when it acts like a fulcrum point, what it will happen is it will act like a scissor. So to prevent this, this has been made as a fixed movable prosthesis, where this stress over here in this particular area is broken with the help of a movable prosthesis. So it has got a lock and it has got a key. So it goes inside the channel and it is able to move. It is able to have a slight movable movement. So when a proposal force is acting on it, the force directly breaks over here and it will directly go to the apex through the root. So the force is not carried to the anterior region. And what is fixed removable prosthesis? So this is given in the condition where if it is a long span or else your ridge is totally resolved, you can't give a fixed FPD. The fixed disadvantage for what will happen is you will have to have a very long rooted tooth or else to replace this. This will be very much unnecessary. So to avoid this situation, a fixed portion consists of two abutment retainers adjacent to the edentulous space is printed with the help of a bar, and the retainers attached to the bar are cemented to the abutments. Like this, it will be connected with bar. And on top of this, a removable appliance is given. A removable portion consists of the artificial tooth and a denture base. So this will be mimicking the gingival area. And this can be taken out or else it can be pressed in the position according to the patient's width. So replacing for such a patient with a conventional FPD will result in unaesthetical long edentulous span. And it can also be used in a very long edentulous span conditions also. You can see that the span is almost 1 meter starting from the molar region and it ends on the premolar region. So this is supposed to be a very long span. So this particular area, how they have taken care of is they have put one Andrews bridge which has a metal studs projecting from the bar area and a counter half with the tooth like this. You can see the acrylic tooth like this, which has an underneath O-rings or a female part which will sit on the male studs. So this is also a fixed removable prosthesis, and this prosthesis can be removed according to patient's will. Now coming to the type of material used. All the materials used are, one is all metal, then metal ceramic, then all ceramic, then metals with resin facing, and acrylic and composite fiber reinforced. Sorry. So all metal means they used to replace the posterior teeth, as they are not in the aesthetic area. The crown is going to be covered with an tooth-shaped metal cover, or else the tube-shaped crowns. Okay, metal which is fully in metal shape. Okay. Then coming to metal ceramic. So this is most commonly used. You call it as PFM, or the porcelain fused to the metal. Here, the metal and the porcelain gets fused together, and the top portion of the occlusal surface, or else the entire surface is covered of the metal coping is being covered with the ceramic. And this is again subdivided into two types. One is metal with which is covering totally entirely. It is covering both the facial surface, lingual surface, occlusal surface, and the proximal surface by a ceramic, and the other one is known as ceramic facings. This is only given for aesthetic purposes. The ceramic facing, the metal, as the name says, it only covers the labial or the buccal surface, and the rest area is covered only by the tooth. Rest area is only covered by the metal. So when the crown is taken in hand, you can see only one side of ceramic, and rest everything which is covered by the metal. And this is used in situations where the clearance is less, the occlusal clearance is less, or else if there is a deep bite. And like such a conditions, this can be utilized. Coming to metal with complete ceramic coverage. Complete ceramic coverage means all ceramic, or as you can call it, zirconias. The metal with complete ceramic coverage. That means all the side of the surface is covered entirely with a ceramic. So this is the picture of a metal facing. So here you can see that the occlusal surface is metal, and the visible surface, the aesthetic surface, the patient, it will be giving a ceramic on it. Okay. Now coming to all ceramic, by the name itself, there is no metal. Okay. As it is, or else it is called as metal-free ceramics. And it, metal-free ceramics means it can be something like Coursera, or you can call it Emax, or else it may be our zirconias. All these things are free of metal, non-cobalt alloys. Now, the last one and the weakest one. These are acrylic crowns, composite crowns, and fiber reinforced composite. They are only considered to be used only in a torsional restoration. And metal with resin facing. With similar to the metal with facing, expects that instead of the ceramic, acrylic composite was used. The resins do not bond chemically to metal. Hence, the restoration should be obtained mechanically by using a small root and retention beads on the basis of the surface of the metal which is on the cast. So there is something known as opaque resin. Opaque is supplied by the manufacturer to be applied on the surface of the metal prior to doing a ceramic work. So this opaque, as the name suggests, the opaque word opaque suggests, it is going to mask the visibility of the metal, and it aids in restoring the color when they do a ceramic buildup. So mini restoration should not cover the incisal edges. All it must occur on the metal. Disadvantage is resin facing wears easily, do not possess a good color stability. So so if you are giving a ceramic facing, so the this brown color is in metal, and this is where the ceramic comes to play. So this is the incisal edge. So on the incisal edge, if it is bent downwards and taken inside like this, the incisal edges are protected and with a metal support. The metal support will be there covering the metal. So what are the types of restoration? It is basically divided into provisional restorations and permanent restoration. In provisional restorations, we call them as temporary restorations. Temporary restorations, basically, we use it for a short period of time. Short period of time, we use acrylic, or else we use composites. So soon after the preparation is expected, till the definitive process is reaches them. A provisional restoration can be cemented with it, and it is also looked at with the help of a weak cement. What are long-term temporaries? These are the situations where you will have the treatment plan is not decided, or else in the conditions where it is the tooth is periodontally weak, or else if he has some medical conditions where more of this stress cannot be sent to the particular tooth. So the fabrication with a special acrylic resin which have additional strength or can be reinforced with the metal inserts. Definitive FPD. So definitive FPDs are the materials like ceramics and metals and are expected to serve the patient for a long period of time. Now, according to the span of the earth, into short span and long span. If you are only replacing one tooth or a two tooth, we call it as short span bridges, which is comprised of 3 or 4 units. Like this, you are replacing one tooth, you are having 1, 2, 3 units. But if you are replacing 4 tooth, so you are having 1, 2, and 3 units followed by 1 and 2 abutments. So they call it as long span abutments. So the types of retention, all it is received from the types of preparation what you do. So all the conventional FPDs are retained because of the frictional resistance offered by the parallel walls of the prepared tool, and the restoration assist by the cement. The micro retention of the resin. Restoration depends on the bonding ability of the resin and the surface regularity of the tissue and surface of the restoration. So, tooth supported. The conventional taking support from the natural maxillary, central, and successor mixing, the abundance is taken as 1, 1 and a 2. Implant supported using the osseointegration. Implants are placed onto the bone. After the healing is done, incisions are secured, and a tooth supported FPD or an implant supported FPD can be provided. Then the other method is to make a support from the tooth, likewise from the implant. It is known as a combination type. So here the natural tooth and the implant are fixed, but the main thing that is to be taken care of is about the gum space, or else the gingival space also. So coming to a conclusion, FPD is indicated in general when 1 or 2 adjacent tooth are missing, the abutment and the support Rotting periodontium should be healthy since it involves preparation of the tooth. It may adversely affect the preparation of the tooth. And FPDs are also taken according to the location, according to the intercostal spaces, and according to the clinical scenario. Thank you.